You're listening to the Primary Care PT podcast. I'm your host, Dr. Katie Obright, and we're going to talk all things primary care PT. Stay tuned and subscribe. Okay, what's up, everybody? I know I took a 1-week hiatus and didn't warn any of you. I'm very sorry, but it is what it is. So this one will be coming to you just 1 week late. I'm excited for this episode because I'm actually going to be sharing a little bit of my story. I think some people know that I unfortunately had to miss the Primary Care PT Summit and Think Tank, which was in part my brainchild, and I had to miss it because I ended up having this crazy thing happen last month. But before I get into the details there, I just want to introduce our guest today. Rebekah Klain is joining me again. And we also have Rebekah Griffith, the ED-DPT, which has been on the show before. She's a friend and a colleague and just an all-around great PT, great person. And she might share a few little tidbits here. So thanks guys for coming on today. Do you want to say anything? Yeah.
Let's go.
Well, yeah, let's go. Let's do it.
Okay, excited to talk about it.
All right, let's do it. So I'm going to, in a nutshell, say this because I could tell the story and make it be really long, but I'm going to do the nutshell version. So for those of you who listened to the cardiovascular episode that I did with Dr. Brian Barney, we talked about his whole ordeal with having the coronary artery anatomic anomalies, where his coronary arteries were actually like a little flipped. He wasn't getting blood flow to his heart. He was passing out, weird, crazy, ended up having open heart surgery. And in that episode, I listened back to it and I was like, oh my gosh, like, what have I been doing? Because I actually shared with him in that episode, I was like, yeah, I kind of have been having some weird episodes. I talked about when I was at the Cubs game earlier. So we're in October 2023 right now. When I was on the episode with him, I talked about being at the Cubs game earlier this summer. It was in June. Somebody hit a home run and I shot out of my chair like you normally would do to cheer for somebody who hits a home run.
I mean, not the Cubs, but yes.
I almost instantly, like, I was sitting on an aisle seat and I looked at the stairs and like just pictured my head crashing into the concrete stairs. And luckily my husband was right next to me, sort of pushed me down, stabilized me. Both my arms went completely numb. I was like, okay, what just happened? That was really weird. But it all kind of got better, and I was there with my family and I was just like, all right, I'm fine. I had just dealt with all this crazy stuff with endometriosis, not even like 6 weeks prior to that. So I was like, I'm not going to get to this taken care of because I'm dealing with too many other things. So anyway, I had another episode about a week to a week and a half later. I was riding, for those who know me, I love to ride my bike. I was riding my bike. I'll go out for hour and a half long bike rides. And some of them can, like, I'll definitely push myself. I like to get after it. And I didn't feel anything during the ride other than my normal palpitations, which when I say normal palpitations, I only call them normal because they've been normal for me for a number of years. And everybody has just been like, oh, it's anxiety. So I just am like, all right, whatever. I'm having palpitations. I'm pushing myself, whatever. So I have these palpitations in the middle of the bike ride. I know my heart is racing. My heart always races. And after I got off the bike, I was, cooled down enough. And I lifted my bike up onto the bike rack and I'm like almost instantly with that like lift and stand, going from like bent over to standing, I felt like the blood rush from my brain all the way to my feet and, had to bend over. But again, couple minutes, gets better. All right. I'm moving on, going to pick my kids up, moving on with the rest of the day. So then I have these palpitations, like I was saying, I have these palpitations. I have these episodes where I feel my heart racing, but this has been going on for a number of years and everybody has called it anxiety. And so I just really like have convinced myself almost that these episodes are anxiety because that's what everybody has always told me. And so, and let me just be clear here. I do have a legitimate history of anxiety. After I had my children, I had some pretty significant postpartum anxiety, and I'm neither ashamed nor, afraid to say that. It was just something that happened and I was treated for it and I moved on from it. And so anyway, fast forward, my son's birthday, beginning of August, we were at Six Flags and I went on the giant drop because it was my son's birthday and he wanted to go on the giant drop, which is like, if you just picture it, 250-foot drop, they raise you up and then they drop you down. After that ride, had the same exact episode. Both my arms went numb. I felt really weak. Like I couldn't lift my arms to like get myself out of the restraints, and felt really sort of jittery the rest of the day. The only best way I can describe it is not exactly lightheaded, but more like giddy, out of body. And now that I know what this is like the mental clouding that they talk about with the condition that I was eventually diagnosed with. So anywho, I finally was like, all right, I should probably just like run this by my doctor. So I go into my doctor fully expecting them to just be like, okay, this is anxiety. Don't worry about it. Because that's what they've always said before. And I finally see this nurse practitioner, a new person who I've never seen before. She was covering for my PCP, and she really did a good job. Like she did a very good job. She did like an orthostatic hypotension test. She did an ECG, like right there in the clinic. She spent like a very good amount of time with me, and it facilitated all of these referrals. So she gets me to this EP cardiologist, electrophysiology cardiologist. So basically these are like, it's like a subspecialty of cardiology that specializes in, the electric conduction of the heart and pacemakers and those kinds of things. And so I see this EP doctor, and he was like, okay, this definitely sounds like neurocardiogenic syncope, but I'm not 100% convinced. Let's do some other things and then come back in 6 weeks. So he wanted me to do a stress test. I wore an ECG monitor, especially during my periods of exercise. And unfortunately, before I got to see him again, I had this crazy episode in the middle of September. I went to the gym just like I normally do, 10-minute warm up on the elliptical, which was very light for me, very light exercise for me. And then I sat down to do my incline bench press, which again, I was doing a warm up set. It was not anything challenging for me. And I instantly was like, okay, my arms feel weak. I'm getting the racing. So I put the weights down, and I was like, okay, it's probably going to clear in a minute or two. I just need to like take it easy. And it did not clear at this time. So I lay down on the ground. And when I lay down on the ground, my heart just starts racing, which is weird because you would think if it was orthostatic exclusively, that if I laid down, it would be better. Didn't happen this time. This time my heart, it was probably in like the 170s or 180s. It had to have been. I was short of breath, arms and legs completely weak, my whole entire body, like just so weak. And fast forward a little bit. Somebody called an ambulance. The ambulance came. By the time the paramedics got there, I was having difficulty talking. So I couldn't form words. I knew what I wanted to say, but I just couldn't spit it out of my mouth. And I was like, oh my God, am I having a stroke? Like, but in my head, I was like, I don't think I'm having a stroke. Like, this is weird because it's both sides. So, so we get to the hospital, sirens, the whole 9 yards, which was crazy, a very crazy experience. Full stroke protocol, whole 9 yards. I was shaking, freezing cold, shaking like crazy. And, after a couple of hours, all tests came back negative. The ED physician he actually spent a good amount of time with me. He thought it was a TIA, and they just didn't capture it in time. And he was like, I don't know what's going on here, but it sounds like you have good, follow-up care. So maybe just follow up with those people. And I was like, you know what? I got kids at home. I'm just going to go. I'm going to go home tonight. So the next morning I felt really, I still felt pretty weak. I felt cold and clammy, and that sensation got worse throughout the morning. So when I called, nobody could get me in, of course. And when I called the nurse triage line, they were like, you probably need to go back to the ED. So I did. And that experience was completely different because while I felt weak and I felt cold, clammy, visibly, I didn't have like the full blown rigors and shaking like I did the day before. And I was able to talk and everything. And I immediately felt upon entry into this ED situation that they were dismissing me. I just almost immediately felt that way. And then that sort of persisted throughout that day. So long story short, they start introducing like, oh, is this anxiety? Is this, it kind of sounds like a panic attack, like anxiety. And I was like, guys, like, I've experienced anxiety before. I'm not anxious. I'm not. Like, I'm in a very good place in my life, and I was like, I don't know why this is happening, but this ain't anxiety. And they just kept kind of like coming back to that. And the neurology NP who came in, she was like, it seems like it's orthostatic hypotension. But the person who did the test like didn't do it correctly. Like, I know how to do the orthostatic hypotension test, and arm completely down by my side, and or like variable positions when they were taking my blood pressure. They only took my blood pressure and didn't take my heart rate with any of the position changes. So anyway, she was like, it kind of seems like it could be that. Also, maybe just add some more salt to your diet. And I was like, oh, salt. Like, okay. Like, salt could actually be definitely a thing here, because I intentionally do not eat sodium or like high salt because I'm so used to telling everybody that it's bad for you. Even when I'm exercising a lot, like, I probably should know that better, but they, so add some salt to your diet. And then I was like, so how do you explain like the global weakness and like the almost expressive aphasia that I was experiencing? And she was like, oh, it's probably just anxiety. So fast forward about a month later, I end up seeing my EP cardiologist again, and he thinks it's POTS and IST, so inappropriate sinus tachycardia, or inappropriate sinus tachycardia. So basically your heart rate racing for no reason. You're just sitting there and your heart rate will spike to 160, which mine has done. And again, everybody has just called it anxiety. So now that I've spent way too long explaining this whole story, I started on propranolol, and the propranolol has been an absolute game changer all around. Like, I do not get these racing heart rate sensations. I'm also doing compression garments, which we know is effective for this. Compression garments and lots of electrolyte water. For POTS, they recommend between 3,000 and 10,000 milligrams of sodium a day, which is a lot. And I think prior to this, I was probably in the ballpark of 500 milligrams a day. So I just wanted to have this, discussion, and I wanted to bring Jess and Rebekah on here because I think that this can open up a lot of information and insight about medical gaslighting. So now that I've told that whole story,
Katie,
go ahead.
At any point, was there a discussion about your anxiety? Was anybody saying, hey, I see this in your medical record, you've discussed it, what do you think? Do you feel like it's anxiety? Or did it feel a little bit more like they had already decided, they labeled you with it, and there wasn't a communication between patient and provider?
There was never a question. There was never a screening form. Nobody issued me a GAD, a generalized anxiety, the questionnaire that is typical for nobody did any of that. There was assumptions made because this particular hospital that I went to is not the normal place where I go for healthcare, but I had been there one time for a test that my normal place for healthcare didn't have. And for whatever reason, the only thing from my past medical history that transferred in when they, were communicating notes or whatever was this past medical history of anxiety. Not that I have a past medical history of endometriosis and shoulder instability and FAI and like all these other things, just that one. And I really got the overwhelming sense that not the first day that I was there, because the first day that I was there, they really saw me when I was in the thick of my issue, heart racing, the shaking, it was nuts. The second day when I went back is when I just really feel like, and then in looking back at my notes, what they wrote, the very first triage like PA that I saw, it was like 34-year-old anxious appearing female. Like, isn't anybody that goes to the ED anxious? Like, yes. Of course I was anxious. I felt terrible. Like, I don't want to be here right now. So no, that to answer your question, not a single person that even mentioned the word anxiety, asked me about anxiety, gave me a screening form for anxiety, nothing. That was the really crappy part about this whole experience.
And then did you feel like there was any opportunity for you to voice what you felt like was different from your past experience with anxiety versus what you were feeling now? And do you feel like it was received at all, maybe a little bit, maybe, Or maybe, I don't want to pigeonhole any of your providers, but I think sometimes when all tests come back negative and they don't have an answer to give you right then, they're still looking for an answer. And it seems like their answer was anxiety because they did not have an alternative solution in that moment.
Right.
Did you feel like that was the case?
Yes, I do. And I feel like that was the wrong assumption. And every single time that one of them mentioned that, I was like, no, that's not it. And in the moment, I almost kind of like thought well, am I anxious? Is there something subconsciously that I'm not aware of? And it's like, the answer to that was like, well, maybe, but I don't think so. And
which
in the
is
moment,
the definition of gaslighting, right?
And in the moment, like you're sitting there like thinking like, well, I really don't think it's this. I wouldn't be here if I thought that it was just this, but I don't know, because you're in this position of authority over me. And like, I think that I know what I'm talking about, but you don't know what I'm like. It was bad. It was very bad.
So here's the thing that I think is the most dangerous about that is that I've definitely had similar experiences, and I get to the point where I can't trust myself. So I no longer, when I have symptoms of any kind, anything, I'm like, oh, it's probably just anxiety. Like, you're probably just making too big of a deal about this.
Yes.
And so I actually had some, what turned out to be a near-death experience where I tried to convince myself it was just anxiety. And I ended up on BiPAP because by the time I actually got medical care, my pulse ox was like 70%. And and the doctor was like, if you had driven yourself home, you would have crashed. If you had gone home, you probably would have just died in your sleep. And then after that episode, I actually ended up with severe anxiety because I no longer could really trust myself to know when I needed help and when I didn't.
Mm-hmm.
And I still have trouble with that. Like, I'll have friends and family say, why don't you go to the doctor? Oh, they're just going to tell me it's anxiety. And I know better. Like, I know how to advocate for myself, but it's just so common. And if it's anxiety, I'm okay with that. Like, I really am. I know how to manage that. I have strategies for that. I know that that's okay. And I can tell myself, hey, I'm safe. Everything's okay. We can manage this. But I need you to be clear that there isn't actually a physiologic issue, because I do have children and I do want to be here for them. And I don't want to ignore things like I did that time. And I'll tell you, I think the other issue is we apologize for wanting that care as well. Because I remember that when I was having a similar heart rate issue checked out when my heart rate was in the 30s, while I was active and treating patients, it was a huge issue. And they were like, it's probably just anxiety. I'm like, you'd think my heart rate might be a little higher than that if it's anxiety. And I remember apologizing to the nurse because I was in my own ED and I was horrified. They had put me in a wheelchair. Like, I was so embarrassed. And I said, I'm so sorry to be wasting your time. It's probably just anxiety. I said that myself. And that nurse looked at me and she said, what are you apologizing for? She says, I have 2 little boys. I would do whatever it took to make sure I was okay for them. And I'm not apologizing for anything. And I was like, oh, okay. And she was like, now sit down and let me put these things on you and let me take care of you. But that was like the only part of that experience that was really focused on, is there a medical issue or not? And I ended up ultimately getting the care that I needed, but it took probably over a year to really get to where I needed to be and what I needed to do. And unlike you, like propranolol, like I can speak English, I promise, would not work for me because my heart rate is so low. So, there aren't a lot of options, but it does take the right person to listen to you, to hear you, to do the right tests, and not just make up their mind about what it is that you have. And when you enable them too by saying, oh yeah, no, I think you're right, it's probably just anxiety. Like, we're doing ourselves a disservice as well. So I think that's the danger, is that we're teaching patients not to trust their bodies.
Yes. To all
absolutely.
All the things.
It's gross.
It is gross. And so I see a lot of post-concussion syndrome patients in my practice. And so POTS is very common. Concussion is very much tied to bringing out some like subclinical mental health problems for some people. Certainly anxiety is part of that. I think loss of identity is a component when people have been dealing with this for months and even years, sometimes even decades. But I have so many people that come into my office. They're emotional. They have a hard time kind of telling their whole story in a way that kind of makes sense from a medical history standpoint, because so much has happened to them in their history. And what I realized when I started treating this population is the first several visits that I have with people, they just want to talk. They want somebody to hear them. And there's very little that I need to do or say in those first couple of visits, other than just allowing them to be heard and providing them an environment where they feel safe and they feel like somebody in the medical profession believes them. And one of the most common things that I hear after even that first session, where maybe we haven't even done any tests or any treatment, they give me a hug and they say, man, I feel like I have a little bit of hope. I have hope that you're here for me. I have hope that you're going to be a part of my team. And my thought is, and the words that I say are, of course, I am here for you. We are going to do everything that we can together as a team. But in my head, I'm thinking, how sad. You have seen primary cares, ED physicians, neurologists, ENTs, OTs, other PTs, speech therapists. And not to say that all of those experiences are 100% bad for people, but they don't feel positive about it. And we have to ask ourselves as providers, why are people not feeling positive about their experiences? And I think all three of us here, and probably most of the listeners, have had these experiences as patients saying, this isn't right. I don't feel like I'm getting the right care. I'm trying to advocate for myself, but I'm still not doing a good job. Or I'm still feeling frustrated or fighting this uphill battle. But we have the ability to flip the script a little bit and at least be somebody that patients can rely on and trust.
Yeah, because once patients start really advocating for themselves, then they're angry.
Oh, I have a story about
that. Then they're
that.
angry and you can't reason with them and they're being totally unreasonable and they just don't care what I have to say. That patient won't listen. Or their family member is so frustrated and exhausted and obviously, if you think about you would do anything for your kids, right? Like I would do anything for my kids. I advocate for my kids all the time. So when I see these family members who are enraged that they've now seen 10 providers and they're at the ED and they're in their last bit of patients, they just cannot hear it. They cannot hear, they don't want to be dismissed anymore. But what we don't see that years of being these patients and their family members being gaslit. So we're well, they're being totally unreasonable. Or we're not going to provide care if you speak to us like that. And it's just, there's a reason people are upset. There's a reason there's a lack of trust in the healthcare system. Some of it's well-founded, some of it's not, but we have to address all of that.
Yeah. So, so exactly to follow up on that. So I was discharged on a Thursday and they, you know how they say well, you should try to get in with somebody within 24 hours after, fat chance.
I try to set up follow-ups for patients from the ED every day.
Yeah. So you call and there's nothing available. So that Friday when I did call, I was like, I feel like I just need some direction, because when I looked at the notes, which of course I'm going to look at the notes, I don't know if most patients look at the notes, but I definitely think as people are getting more, in tune with people that are in tune with their health and interested in knowing the direction, they're going to look at their MyChart notes or whatever, is the EMR that's available to patients. Every patient should be able to see their own medical records. So of course I'm going to look at my notes, and I look back at the notes and, the hospitalist, the ED physician, the neuro NP that I saw all kind of start their subjective with, 34-year-old female with past medical history of anxiety. And that automatically sets anybody who's reading that up for oh, I know what's coming here. Or at least, I don't know, maybe I'm biased and maybe I'm being too hard on the situation, but that's what I think of. And then when I reviewed the neuro NP's note, it was completely backwards. She didn't get my story right at all. Like, and that to me is like, if you didn't get my story right in your note, then you gave me the wrong information. You gave me potentially the wrong diagnosis and the wrong guidance and the wrong education because you didn't get my story right. And she blamed this thing on anxiety when like she said that like I went to the gym the following morning and I just like showed up to the ED with this random event where I couldn't move my arms and legs and like had expressive aphasia. And that's what she was like, oh, that was probably just anxiety. Anywho, so I'm like, well, after reading this note, I'm way more concerned and way more confused and way more like, what exactly happened? She didn't even get my story right. And therefore her opinion is completely unreliable to me. And I don't even care about what she said. So what am I supposed to do now? So I tried to call and I was like, okay, well, so the receptionist on the phone was like, okay, somebody's going to call you back. So somebody called me back. It was an NP from the cardiology department. And so I'm like trying to figure out like, asking questions because my cardiologist wasn't available. Trying to ask some questions. And, I'm like, so they told me to kind of increase my salt, which kind of makes sense because I work out a lot and, I definitely don't eat enough salt. And she was like, well, no, don't increase your salt. Just make sure that you're drinking enough water. And I was like, okay, but they told me specifically to like increase my salt. So do we think that's something that I should do? You're telling me the opposite and you haven't even seen me. This is just a phone call. Anyway, so like she's telling me this stuff. I'm kind of coming back to her and saying, but I'm not sure that is correct because these people told me something different. And she just keeps going on and on about like all of these basic things, like don't increase your salt, just make sure you're getting 64 ounces of water a day because that's like half your body weight. It's all these arbitrary things. And then she goes, well, what's one thing they tell us? They tell us look for horses, don't look for zebras. And I was like, but if you're always looking for the horses, you're going to miss the zebras because I know exactly what you're talking about. And then she was just like, well, I've been doing this for 40 years, blah, 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 blah. So I go back and look at her note after this because at the end of that conversation, she was just like, have you been checked by mental health? And I was just like, I'm done. I've already heard this enough. And you know nothing about me. You know nothing about my medical history. And for you to just jump right there is so dismissive. And, I finally was just like, I'm done with this conversation. So I go back and look at her note and it's like argumentative, 34-year-old female, blah, 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 blah. Like just basically all this stuff about how I was really argumentative on the phone. So if you
I
try
have
to
definitely
advocate,
gotten argumentative female in a note before. And I'm like, oh, sticking up for myself and telling you in a clear manner is being argumentative now?
yeah. Yes. And so that forever is in my medical record that I am an argumentative female because I did not think, because ultimately, and looking back now that I do have this diagnosis, what she was telling me was not correct. It was not accurate. It was not correct. I was trying to advocate for myself. And you're just sort of labeling me as an argumentative,
I think the problem with that too is that they're not taking into account who you are, right? Like that patient centered. So one of the things I got in one of my notes was patient has heart rate data that they've collected from their Fitbit. And I was just like, okay, I'm in a remote data monitoring study with a Garmin. I have been tracking my data trends for years. I'm well aware of what's normal, what's not normal. I monitor all of these things. And yes, there are abnormalities here. I also am a trained professional who understands how to utilize heart rate data and how to detect abnormalities in heart rate data, particularly with activity and rest. Because if I don't do that for my patients and I hurt someone, it's a huge problem. So and their solution to my presenting them with this data that I thought would be really useful, like if a patient came to me with that data, I'd be like, this is really helpful, thank you.
Totally.
Was told patient to stop wearing activity watch due to hypervigilance.
That's offensive.
Whereas
not only offensive, but it's unsafe.
Yeah. So, I think it's And we all know theoretically how to advocate for ourselves, right? So I think about my patients that come to the ED with no health literacy, who don't know what to do. They don't have follow-up. All they get is that 5 minutes in the ED. They get that discharge summary with vague instructions. Maybe increase your salt, drink a lot of water. Both of those things kind of don't go really well together, right? Like drink a lot of water and eat a lot of salt. Like, I mean, it's not very clear. And so when we send patients out with no follow-up, no instructions, no understanding of their condition, there's a reason they keep coming back. They don't know what to do. They're not getting any help. They don't understand. They don't know how to advocate for themselves. And so I think as clinicians, we have to be really mindful of that as well.
Yeah.
Hypervigilant.
Yes. And trust me, like anxiety is a very real thing. And it is something that a lot of people struggle with, but it's also something that a lot of people struggle with transiently here and there.
Yes.
Like it's not, and this is the problem that I had with my situation is I had this in my medical record. I also have other things in my medical record that I'm no longer dealing with. And so why is this the one thing that the way that I phrased it was like, this is like having a scarlet letter on your face.
The worst.
But, and I couldn't believe it that in 2023 that we're still doing this. I
actually think it's worse. And people use this whole patient-centered care or psychosocial emotional care paradigm to justify it. And so I'm kind of seeing that weaponized a little bit. Well, we have to consider the psychological contributing factors to this patient's diagnosis. Of course we do, but that's not the way to do it. And that's not the way to dismiss that. Like I might have approached you.
The diagnosis.
No.
Either, right? It can exist with other things. Like let's say it is anxiety in that moment, but that doesn't automatically mean that there isn't something else also going on.
Yes.
Side by side, in addition to, or one causing another, or a cycle of things causing each other.
And why wouldn't you feel anxious? You have an unexplained medical condition and you feel like you can't get help from anyone. So I have patients ask me, they'll say, do you think this is just anxiety? I said, it's definitely a possibility, but I think more likely you feel anxious about this situation.
Yes.
And for me, when my heart felt like it was going to stop at 37 beats per minute while I was trying to work with patients, yes, that made me feel anxious.
Well, of course it would, but like, there's a difference between the feeling of feeling anxious.
Yes.
Like when in POTS, they describe this a lot because since I actually have had this diagnosis, I've looked into it a lot and read a lot of people's experiences. And when you have those episodes where your heart is racing really fast, it almost it takes your breath away a little bit. And that almost that does make you feel anxious in the moment. However, anxiety, when they look at the population of individuals who have POTS and IST and other types of dysautonomia, anxiety in that population is no more prevalent than in the general population. And even in some studies, they showed that it was lower, that there was like a lower, but a lot of individuals that ultimately do have POTS or other forms of dysautonomia or other types of heart arrhythmias, they are often mislabeled as anxiety because people don't know it. Well, people don't know enough about it, or they're just totally not seeing it. Like in the ED, the first time that I went, I remember them being like, well, your blood pressure's pretty stable. But nobody was ever like, why is your heart rate like 140 just laying here? And why are you shaking? And why, like, you know what I mean? Like, it was just this, like, they were all just so hyper focused on the prospect of it being a stroke, which they should, that's the most serious thing that it could have been at that time. But once they ruled out, like, nobody ever circled back to that. So I don't know.
And, you mentioned this, one of your providers saying, look for horses, don't look for zebras, which makes sense in some scenarios. But let's be real here. POTS is not really a zebra diagnosis anymore.
No.
It is very common in the post-concussion world, and it's also very common in post-COVID. We are seeing a lot more of it. And sometimes I question, are we seeing a lot more of it because we are more aware of it and we can recognize it better and we know how to treat it better, so we're more willing to diagnose it? Or are we actually seeing an uptick related to the COVID virus? From my perspective as a PT, I don't really care why we are seeing more of it, but if somebody fits into that category, PTs are in a prime position to help people understand it, manage it, help your body regulate itself to maybe get yourself out of this POTS, or get yourself out of POTS running your life.
Right.
And that is something that we can help diagnose people with, because we get to see people, we hear them more, we can test their heart rate in different positions, different activities, maybe ask them to wear a Garmin watch and actually use the data, right? But I think part of it is we are relying, rightfully so, on ED physicians in this state of emergency to help us figure out what's going on. But really, we need a better care team for those patients that get those vague discharge instructions, and say, who are you really going to go see, and who's going to be the person that's not only going to help you follow up, but actually help you get better from this as well. And that there's a gap in care for sure.
And we're going to circle right back around to barriers to access to care. Because how long does it take you to see a specialist? A real long time. And that's well insured, well connected, like good health literacy is still going to take you a really long time. So I think a lot of these things get missed, and more of that responsibility is landing on the ED when their real primary role is to like stabilize and triage and move you along to the next step. That's not their job. So there's just huge gaps everywhere.
Yeah. And one of the things that I think, and in my case, they were focused on consult to neuro when I was in the hospital. They hadn't really looked into consult to cardiology, even though I said, I have been seeing this cardiologist. He thinks this, I think he's right. But they just wanted the consult to neuro. And I kind of think that some of the decision-making for, the types of consults or the types of like discharge instructions that you receive, can definitely be optimized. However, I will throw this caveat out there. And even the second ED physician that I saw the next day, he was like, I'm not sure, like this could be anxiety. Like it could be, but it could be something else. I don't know. Our job in the ED is to make sure that you can stay alive. And if you are alive, then we try to involve other physicians and other providers to help us with our decision-making, because we don't know.
Right.
And I appreciated that. Of the whole scenario, I really appreciated that perspective, because I was like, I get it. Like, I get that this is like, that your job is emergency stuff, making sure the patients are stable. But for these people, like I actually had another episode the following week, because it was before I saw my cardiologist again. It was before I was medicated. I took my dog for a walk. I had another episode where my heart was spiking into the 160s, 170s, and it wouldn't calm down. And it was really bad. And I definitely feel for a lot of, this was before I had even considered the prospect of POTS. And I was like, oh my gosh, I'm an AFib. I'm going to die. Like, this is something is wrong. Something is very, very wrong. And I probably would have gone back to the ED had I not talked to my cardiologist over the phone, and he was like, I think that these episodes are not life-threatening. With that being said, if you feel like this is out of control, don't not go to the ED because I said that. But right. I decided not to in that circumstance, and it did eventually get better. But I don't know. I don't know. After that experience, I have a lot of I have a lot of trouble feeling good about sending patients anywhere. Like I can't even believe I'm saying that, but I've just noticed that attention to detail and good clinical reasoning and good putting the whole picture together with other healthcare professionals has not been very good lately. And
well, this is when I'm going to tell you my soapbox about specialization, right? When we have too many people that are specialists, they can only see what they specialize in, and there isn't anyone to put the whole picture together.
right.
So I see that a ton. I've seen the cardiologist, I've seen the neurologist, I've seen the ENT, I have seen my primary care doctor, I've seen my psychologist. No one can help me.
Mhm.
Okay, you have BPPV, like let's get you to see a physical therapist, but nobody can put up all of that together. Or I see a patient who's had a CT, an MRI, they've been in the ED for 24 hours. I do an orthostatic hypotension test and they're like perilously low. Why did it take that many people for me to figure that out? And why was it the physical therapist that did that? So I think you've heard me say a million times, like the whole jack of all trades is a master of none quote is incomplete. It's a jack of all trades is a master of none, but oftentimes better than a master of one. So we
Mhm.
still need people
Yeah.
that can see the whole picture and put it
Yes.
together, that can
Yes.
take all of those pieces and put it together, because that's missing.
Yes, thank you. And I think that ideally, a lot of these specialists, and this is PTs included, a lot of these specialists rely on primary care and family medicine and internal medicine to like put all the pieces together. But unfortunately, in our current system, primary care is not given the time nor the resources to make that stuff happen. It's not because they don't want to. It's because the infrastructure in place, like, oh, here, you have this many patients on your panel, you see this many patients a day, you only get this amount of time per appointment. And the appointment, like stratification, like you call with a certain thing and then they put you in a 10-minute slot versus a 20-minute slot versus a new patient slot. All of that has gone to crap because so many primary care physicians are leaving. Like we live in the Chicago metro and my husband waited like 5 months to see his primary care provider, his primary care physician.
Yep.
Like
Denver,
what?
I waited 6 months to find a new primary care. He did spend an hour with me, but everything was surface level. Like I'm trying to tell him more stuff and it's like he can't, an hour still isn't enough.
Mhm.
Whereas, outpatient PTs, I can accept the fact that in our first hour session, we might not get to everything. And that's completely okay,
Mhm.
because I'm going to see them later that week or the next week and the following week and the following week. And sometimes it's me needing to ask the right questions. Also, it's patients don't always have the ability to know what's important to tell us.
Mhm.
So you got to really bring it out. And sometimes it's a random flippant comment that they made about something that happened 5 years ago that all of a sudden opens up everything.
Yeah.
And primary care physicians and any of the specialists, even if they had more time with them, they don't necessarily have that relationship that we get to have with people, which I think puts us in an amazing position to be a more central piece of consistent patient care in addition to everything else.
I agree 100%. And this is why I'm such a fan of the direct primary care model, because when I had a direct primary care physician when we lived in Pittsburgh, I feel, for those that are unfamiliar, the direct primary care model is you pay like a fee per month and then you get unlimited access to your primary care physician. And it's like a subscription membership type model. And it's not an outrageous fee. I think I was paying $70 a month. It was like very affordable. And it was awesome. She spent the time with me that I needed. Maybe if we didn't cover it one day, we would just pick up where we left off, and it was flexible. There was in-person options. There was like the doxy.me. There was like lots of different options for me to make sure that she could put all these pieces together. And she stinking did, and got me like on the right track to figuring out that I even had endometriosis, which is another condition that like people go many, many years before. And I totally gaslit myself too, Rebekah, with that. Like I was like, oh, I just have chronic pain because of like what it was ingrained in me with this whole central sensitization concepts. Like I was jumping too soon to that. And I'm worried that I jumped too soon to that with other patients too. But I'm a huge fan of the direct primary care model for that reason, because people are more complex than they seem on the surface level. And that gives you the opportunity to make sure that you are addressing all of the, peeling back the layers of the onion, let's talk somebody mentioned this earlier. Let's talk a little bit about the role of sex in this, and that being like, we all sort of speculate that if it was a man in this circumstance, which all three of us are women on this call, but we speculate that if you replaced me in my exact situation with a man going into that ED the very first time, or even the day after, would there have been the amount of anxiety labeling and sort of brushing off if it was a man compared to a woman? And especially a woman under 50. What do we think about that?
I mean, I would love to say that I don't think it matters, because I don't think it should matter, right? I don't think it should matter that your age or gender in an emergency scenario should dictate the potential labeling of anxiety. I think it does. And I think sometimes we can point to the research and say, well, that's why, because statistically, females under the age of 50 do generally report more anxiety. But I'm going to take it a step further and say, well, is it because we as females under the age of 50 are more willing to be honest with how we're feeling and maybe admit to the fact, hey, I think this could be anxiety playing in a role, and I want to seek treatment for it? So I think that there's a lot of things that can feed into that. And we can say, there is a component of bias, but there is a component of some data behind it that might justify some people thinking that in the back of their head. But we have to overcome that data. Again, horses versus zebras. Like, that's not a fair statement in this scenario, because this isn't really a zebra, right? This is a common, POTS is a common diagnosis, and you shouldn't have been put in this category of it's only anxiety, or it's only this super rare random thing that probably you don't have.
Mm-hmm. Yeah, totally.
I would say that anecdotally, my experience is that women are more likely to be dismissed with anxious behaviors, but men are more likely to be told they're being a baby. Or, oh my God, that guy in room 3, he's just the biggest baby. Like, I feel like men's pain is often dismissed as well. They're just not very tough. Like, I hear that a lot. He's just a big baby. He's just whining. So I hear that. And then women is, oh, she's just anxious. She's just anxious. She's got kids. Of course she's anxious. Like, things like that. So I think there are probably different gender differences a lot, but I feel like my husband and I have had this conversation, because when I was seeing the cardiologist, he read the notes, because I said, I feel like I am being dismissed with anxiety. And he was like, no, I'm sure that's not the case. Like, and then he read the notes and he was like, ew, no one has ever said anything like that to me before. No one has ever written anything in my chart like that. Mm-hmm. And so he went to some appointments with me, and he was like, like, I never am spoken to like that. And I will fully admit, when I go to the dentist, I'm an anxious appearing female, like 100% cannot manage it. Tears, like hyperventilation. I like have serious dental trauma. I am 100% anxious. There is no other diagnosis. It is anxiety. Can confirm. And I've never even let him go with me, because I don't want him to see me like that, because it's so ridiculous. And he said, have you considered having me go with you? And I said, I can't have you do that. I'm just too embarrassed. And he said, but I could advocate for you, because no one's hearing you or seeing you. And I think people are just shocked at how anxious you are. But if I go with you, maybe I can like be your voice. Mm-hmm. And so I thought about that too. Like, how sad is it that we really need that somebody to advocate for us before we're being just dismissed as being mm-hmm. anxious? And I don't know if that happens to other genders, but in my little brief anecdotal study of 2, it does not.
I think that in in putting all of this together, I've had a lot of medical things as somebody who is, my age, and I always get the, you're young, you're healthy, there's nothing wrong. So I do exercise quite a bit. I am quite fit. I eat very clean. But I do all of these things because I've recognized that they make me feel better. I've had a lot of health struggles already. And I know that I need to do like certain things. Like if I don't exercise, I'm going to have like a little bit of pain, like my neck pain might come back or my this and that. And I just think that sometimes I sort of lost my train of thought, which this happens to me at least once a podcast.
Well, I think I know where you were going with this, right? Like people make a snap judgment and they're like, oh, you're young, you're fit, you're healthy, you exercise, you eat well, you're fine.
Yeah. Yes.
Everything's fine. And you're like, except for this major big thing that I'm in here for, saying I need help with, I don't feel fine.
Yes, that is exactly where I was going with this. I actually did have a nurse tell me one time, she was like, but you're 31. Like we have a lot of patients who are like really sick here. And I was on the phone and I was just like, oh, like, I guess I don't matter. I guess nothing that I'm dealing with right now matters because you deal with a lot of people that are really sick and you think that I'm not. So, okay, well, I'll just not ever come in here again. Like that's kind of how I've felt. And I don't like going to see new doctors because I go in with the expectation that they are going to dismiss me. And I almost feel like I have this little bit of a front when I go in there. Like I already have like a wall up because I just expect them to behave like that or act like that or treat me like that. So I just don't, in dealing with all of these things, the only thing that I want to do is make sure that I never, ever treat another human being like that when they are in my care. Or if I'm even just like friends with somebody, I don't ever want somebody to ever feel like they are not heard, that something is being missed. I want to make sure. So this has almost made me clinically go over the top with like, I hear you. I understand you. I care for you. Maybe I don't know what's happening right now, but we're going to get to the bottom of it. And I can be on your side and be your team member and be your advocate. I like go over the top because I really want to make sure patients understand that when they're in my care.
100% second that without a doubt. And it's really nice when patients recognize that right off the bat and the amount of trust that can be built between that patient-client relationship and then how much more you can accomplish because that patient trusts you, because they know that they can say anything that they feel like they need to relative to the care that you're providing or not. Sometimes people we're all humans, right? People need to, get things off their chest, be emotional, cry it out sometimes. And to have a safe place for patients to do that is absolutely a game changer in the care that I'm able to provide for them and what we can accomplish together.
Yeah, absolutely. Rebekah, any parting thoughts?
I would say the last thing that I do with patients who might actually be anxious or that's being discussed is I talk to them about what is happening versus what if. So right now I need you to focus on what is happening. And right now what is happening is I'm going to examine you and we're going to figure out if anything dangerous is happening. And if not, then there will be a new plan after that. But what I need you to stop thinking about in this moment is all those what ifs that are causing you stress. What if this is something really serious? What if I can't go home today? What if I can't go to work tomorrow? All of those things are making you feel worse in this moment. So together, you and I are going to focus on we're going to do one step at a time. And that often helps people really be able to like center to the moment, help get through a good exam. It helps both of us kind of set aside that piece and get to what we need to do so we can make a good plan for those patients.
Yeah, absolutely. And I think just anybody listening, just remember that everybody that we ever come across has a story. They have pain and frustration and fear and a lot of things, and they might come in with a wall up. And it's our job to not be to not, take offense to that or not feel frustrated ourselves by that, because probably they're just they wouldn't be there if they didn't want your help and your input. So it's your job to sort of make sure that you are creating a space where they are feeling like you are indeed listening to them and hearing them and want to help them. So I think if anything, we should just make sure, and I always tell students this, like, chart reviews are good up to a certain extent. Don't chart review the crap out of your, so much so that you're biasing yourself before you even meet this individual. And if you find that that's the case, stop doing chart reviews and rely on your own judgment. And then maybe after the fact, after you've met with the patient, then maybe go back and do a little bit of chart review just to confirm a few things. But that's something that I see often, especially in students. And I see that all the time. It's like with doctors, I find that often they are relying way too heavily on the chart review and not or whatever the nurse tells them, instead of actually forming their own opinion, unbiased, totally objective opinion. So, any parting thoughts before we wrap up on this episode? And then in the next episode, I'm just going to do an overview of dysautonomia and what POTS actually is, and IST, and some of these other, heart rhythm issues that are related to dysautonomia. Any other parting thoughts, y'all?
No, I think we covered a lot. I mean, this is something we could talk about forever and ever. Everybody has a story, like you said, good and bad. And all we can do is, take our own experiences and be better moving forward.
Absolutely.
Totally agree. Thanks so much.
Thanks so much for coming on. See y'all next time. And that's a wrap. Thanks for listening. If you love our show, go ahead and subscribe to stay tuned for future episodes. As a thank you to our listeners, we're happy to offer $50 off of our Primary Care PT Foundations course or our Musculoskeletal Imaging certification. Visit us at redefinehealthed.com and use code PCPTPodcast, all one word, all lowercase, on the checkout page to claim your discount. That's PCPTPodcast, all one word, all lowercase. Until the next episode, stay awesome, y'all.